Hello, everyone, and welcome to the webinar tonight regarding shoulder and knee pain. Um, I am Dr. Scott Smith, and it's a pleasure that I really appreciate everyone coming in and taking time out of their evening to listen to some options and some of the cutting edge technology about shoulder and knee pain. Um, so a little bit about myself. I'm a Hoosier and an Indianapolis native. I grew up on the north side of Indianapolis and have spent my entire childhood here. Um, I went to North Central High School on the north side of Indy. My parents still live there. And I attended DePauw University for undergrad. After high school, I played football there for a couple of years and was heavily involved in the athletic department there. And decided that I wanted to go into medicine. From an athlete's perspective, I had several injuries um, while as an athlete and had some very good surgeons and mentors kind of guide me towards this career choice. And I haven't looked back. For my medical training, I also went to Indiana University for my medical training. I spent the first 2 years at the campus in Muncie, Indiana. My final 2 years doing my clinical rotations at the medical center downtown. And after medical school, when I was lucky enough to match into orthopedics, which was my desired field of choice, I decided it was probably time to get out of the state of Indiana. So I spent 5 years in Milwaukee, Wisconsin, at the Medical College of Wisconsin, completing my orthopedic surgery residency. And then after my residency, I decided to subspecialize in sports medicine. So I was lucky enough to accept a position at the Ohio State University in Columbus, Ohio, where I got to work with the athletes and the surgeons there, which was a lot of fun, and I got some really good experience about that. So um, the question, what do I do as an orthopedic surgeon here at Riverview? Well, first and foremost, I am a uh, general orthopedic surgeon, which means I take care of the vast majority of orthopedic conditions. I take care of most basic fractures from toddlers all the way up to the elderly, and oftentimes have to operate and fix these types of fractures as well. But the vast majority of my practice does um, focus around the shoulder and the knee. And some common conditions that I treat regarding the shoulder and knee are the shoulder tendon tears, mainly rotator cuff tendons, shoulder instability, where the shoulder dislocates, and as well as shoulder arthritis, where the cartilage wears down. And then for the knee, in a similar fashion, I treat ligament tears, meniscus tears, cartilage injuries, and when the final stage is arthritis. The vast majority of my practice contains both operative and non-operative treatment. Obviously, recommend surgery for when it is in the best interest of the patient, but the vast majority of the time, we do focus on non-operative treatment to get people the pain relief that they deserve. And one fun part about my job being a sports medicine physician is that I get to um, cover local teams in the community and help provide sideline coverage for the athletes there. So I'm the team physician for the Westfield High School and the Westfield School District. So this picture on the top right was myself and some of the athletic trainers I get to work with uh, at the state championship game this year. So I got to be on the field for that, which is a lot of fun. And then part of my fellowship training on the bottom picture, that was my perspective at the Ohio State Michigan game, which was quite the experience. So we'll begin to talk with shoulder. Um, a little quick anatomy lesson. The shoulder is the most complex joint in the body. It's comprised of three different bones: the humerus, which is the arm bone; the scapula, which is the shoulder blade; and the clavicle, which is the collarbone. Um, there's actually two joints in the shoulder area. There's the glenohumeral joint, which is the ball and socket joint, which most people think about. And there's the acromioclavicular joint, or the AC joint, which is the joint between the collarbone and the shoulder blade, this area called the acromion. So oftentimes pain can be related to one or both of those conditions, or those joints, excuse me. But the vast majority of shoulder problems tend to stem from either the cartilage or the rotator cuff. Now, the rotator cuff um, is well known to most people, and it's probably the most common shoulder condition that I treat. There's a lot of misconceptions about what the rotator cuff actually is. The rotator cuff is a junction of four separate tendons that come from four muscles: the subscapularis muscle in the front of the shoulder, the supraspinatus on top, and the infraspinatus and teres minor in the back. These tendons kind of form a covering over the top of the humerus, or the arm bone, and their main function is to help stabilize the shoulder so it doesn't dislocate, as well as provide a fulcrum to help lift the arm in space. Now, unfortunately, with this important job that the rotator cuff does, it is prone to several pathologic or conditions. The tendon does have a lot of strain on it, particularly the top tendon, the supraspinatus. So it is prone to wear and tear with time, as well as it can be prone to injury after a fall or a shoulder dislocation. As we age, the blood flow in the tendon does diminish somewhat, which does make the tendon prone to wear and tear, what we call degeneration over time. However, patients can tear the tendon abruptly with a major traumatic event like a fall or a dislocation. Now, some symptoms related to rotator cuff pain. Now, the location of the pain oftentimes is not directly in the shoulder itself. It's oftentimes referred to the outside part of the arm, sometimes the back of the arm, and patients can even have pain radiating down into the elbow. Oftentimes, as a secondary source of pain, the pain can actually radiate into the neck and to the back of the shoulder as people don't use their arms properly because of pain. It actually puts more strain on the other muscles that attach to the shoulder blade. But the hallmark of pain associated with the rotator cuff is pain in these locations, both at rest and with activity, particularly with overhead activity, raising your arm above shoulder height. And for some reason, we don't exactly know why, but pain at night when trying to sleep is very, very common with shoulder conditions. Patients can also present with weakness or feeling like they don't have the strength to lift the arm above their shoulder height. Can be condition we see, symptom that we see with chronic rotator cuff problems. Now, when you present to an orthopedist office like myself with shoulder problems, the most important thing that we do is thorough history and examination. Oftentimes, just by talking with the patient and doing a good examination, we're able to get a very good idea about the source of the problem. Usually the first time a patient visits me, we are getting x-rays. And while we can't see tendon on x-ray because a tendon does not have calcium, and x-ray picks up structures that have calcium in it, we get an overall picture over the health of the joint regarding arthritis, as well as there can be different changes that we see with people who have rotator cuff problems for a long period of time. And sometimes, depending on the situation, we also consider obtaining MRIs of the shoulder. Now, an MRI is not an X-ray. It's a scan that uses magnets to develop a picture of the tissues in the shoulder. And this is the best modality to look for rotator cuff problems. So in this picture that we see on the bottom left of the screen, the rotator cuff muscle, the top one, the supraspinatus, is this kind of gray circle right here that turns into this black tendon. And normally this tendon attaches to the outside part of the humerus, forming that covering. However, in this MRI, that tendon is torn and actually retracted a little bit. So that is evidence of rotator cuff tear. Now, when discussing treatment for rotator cuff tears, the good news is the vast majority of these problems do resolve with non-operative treatments. Some of the studies that we've done have showed that about 80% of patients do get relief to some degree with non-operative treatment. And the treatment for these problems can vary from everything from just rest and changing activities, avoiding the activities that tend to bother the problem, particularly with repetitive overhead lifting. Um, but usually the most common thing that I prescribe patients with rotator cuff problems is physical therapy. I know a lot of patients don't like going to physical therapy because it takes a lot of time, and there's a conception that therapists are there just to hurt you, which is not true. But the whole point of physical therapy is to correct any changes in the mechanics of how a patient is using the shoulder, as well as strengthening the rotator cuff and the remaining muscles to help alleviate any strain on the shoulder, as well as they have various modalities to help decrease pain using things like ultrasound, electrical stimulation, things like that are very helpful for pain. And sometimes as well in my office, when a patient has tendonitis or pain related to the rotator cuff, and I'm not concerned about a lot of weakness or bad tearing, we do consider some injections in the shoulder. Typically, what patients are known as cortisone or steroid injections. And what that is, it's a very strong anti-inflammatory that we put around the tendon to help decrease some inflammation and help alleviate pain. And usually the injection is done in conjunction with some physical therapy to help keep the problem at bay. However, sometimes patients do present with large tears of their tendon, or the non-operative treatment does not give them the relief that they want. So we do quite a bit of surgery on the rotator cuff as well. We save surgery for patients with these problems when they have pain that is just completely unrelieved by a non-operative treatment, or patients have significant weakness with the shoulder. Usually that's indicative that they have full thickness tearing. Unfortunately, rotator cuff tears tend to progress with time. So when I evaluate a patient who does have a full thickness rotator cuff tear, we tend to want to fix those sooner rather than later, so the tear doesn't progress to the point where you can't repair it and you have to do something more invasive like a shoulder replacement. We also tend to do surgery more immediately for patients when they have an injury to their tendon, evident what we call an acute tear, where a patient was doing well beforehand and they had a fall and completely pulled the tendon off the bone. Those don't get better typically without surgical intervention to reattach the bone, up the tendon to the bone. And the good news is for these rotator cuff problems, the vast majority of the time we were able to do this surgery arthroscopic. So the pictures on the top left here are a cartoon of what an arthroscopic surgery looks like. The surgery entails multiple small incisions where we put a camera into the joint and do the work through these very special tools using very small incisions, so we don't have to make a very large incision. So a good picture on the bottom left is with the scope in the shoulder with the humerus and good cartilage on the bottom, and the rotator cuff tendon on top. We should see that tendon fully attached to the bone, whereas the instance on the right, we see a large full thickness tear of that tendon that can be repaired. So when someone does elect to have a rotator cuff surgery, there's quite the experience that goes along with that. Basically, what we do during surgery is we use these small anchors that we screw into the humerus bone. This picture on the bottom here, some of the anchors that I use. Basically, these anchors are made of a composite material that your body actually absorbs and then turns into bone. But then they have these high-strength sutures attached to them. And so what we do is on like this picture on the top left here, there's a patient with a very large rotator cuff tear. We place these anchors into the bone, pass these stitches through the tendon, and tie the tendon back down to the bone to get it to heal. Now, the surgical experience is quite a whirlwind for patients because we meet a lot of people, a lot of great nurses and anesthesiologists. But from a general experience, on the day of surgery, I usually have anesthesiologists perform a nerve block. And what that is, it's the anesthesiologists do a great job at finding some of the sensory nerves, of the nerves that come from the neck down into the arm, and use ultrasound to numb, inject local anesthetic around these nerves to help completely cause the arm to go numb. We're able to do this because we obviously don't walk on our arms after surgery. So we can completely numb the arm and actually use less general anesthetic to keep you asleep during the surgery, and also helps with pain relief for about a day or two after surgery. Surgery itself, depending on the degree of tearing, usually takes about 90 to 120 minutes, and patients do wake up in a sling and usually go home the same day. Total recovery from rotator cuff surgery can be long. I usually quote patients that it's about a 6 to 8 month total project before it's all done. However, general way therapy typically progresses is that we tend to spend the first 6 weeks in a sling after rotator cuff surgery. That allows time for the tendon to heal to the bone. For those 6 weeks, patients are not doing much in terms of active motion or lifting their own arm. However, we do start physical therapy very early to have the therapist help mobilize the arm early, so we can prevent as much stiffness as possible. And then once the 6-week mark comes after surgery, as long as the patient's doing well, we generally get them out of the sling and really start aggressively having them lift their arm and rebuild their strength and get back to normal life. And so some websites associated with some great information regarding rotator cuff recovery. This picture right here I got from the website. It's called orthoinfo.com. It's put on by the American Academy of Orthopedic Surgeons, and has some great home exercises as well as common things that I use for my therapy program afterwards. With any of the surgeries we talk about today, I have a very specific rehab protocol that physical therapists follow. This protocol was developed by some of the therapists and surgeons that I've worked with in the past. There's a lot of good research behind how quickly to get patients back. Like we said, with rotator cuff surgery, it's not a quick recovery, but the vast majority of patients get back to full level of activity, and then once everything is healed, then there's no restrictions on the shoulder long term. I will say though, we will have a question and answer session afterwards. So if you have a question that comes up, you can write down the chat feature, and we'll be happy to answer them at the end. So we'll change topics a little bit and focus from rotator cuff tears to shoulder arthritis. Now, arthritis is a very generalized term for basically breakdown of the cartilage within a joint. Typically, breakdown of the cartilage causes pain. Oftentimes, there's inflammation or swelling associated with this. And it's particularly with the shoulder, there's quite a bit of stiffness that comes along with shoulder arthritis. Now, our type of arthritis we will talk about today is osteoarthritis, which is by far the most common. And basically, this is wear and tear. There are many different causes for osteoarthritis. Having previous surgery is a risk factor. Multiple injuries or dislocations can be a risk factor. There oftentimes is a genetic component as well. Arthritis tends to run in families, as well as unique to the shoulder. Having a bad rotator cuff tear for a long period of time can cause the shoulder to get arthritis as well. That's a condition that we call rotator cuff tear arthropathy, and we treat that a little bit different than regular shoulder arthritis, and we'll talk about that in a second. So when a patient with shoulder arthritis comes into my office, again, we start with the physical exam and the history, which is by far the most important part to this. The biggest thing we want to evaluate with a patient with shoulder arthritis is whether or not they actually have a good rotator cuff or not, because that helps delineate the type of treatment that we feel for this. Um, Often, the hallmark of shoulder arthritis typically is stiffness, meaning that they don't have as much motion as used to, particularly with rotation outward away from the body. Patients oftentimes feel grinding, a medical term called crepitance, as the smooth surface of the cartilage kind of breaks down and becomes roughened, and then oftentimes causes popping, can cause locking as well as grinding. X-rays for arthritis look a lot different than X-rays for rotator cuff. So in this X-ray here, we see that there are bone spurs that have been formed off of the edge of the humerus bone, and that's just the body's reaction to a joint that is losing its cartilage. We also see narrowing of the joint space, meaning the space between the humerus here and the socket or the glenoid here. The space basically becomes what we call bone on bone, or the bones are rubbing against each other because the cartilage is all gone. Sometimes in a patient with arthritis, even though we know they have arthritis, we still sometimes get an MRI, and that would be to look again for the rotator cuff, because that can change how we decide to treat this problem. And oftentimes with shoulder arthritis, when planning a surgery, we do get a CT scan, and that's to help get a good picture of 3D picture of what the bony deformity from the arthritis looks like, so we can plan the surgery, and I'll talk about more of that in a minute. So treatment for shoulder arthritis, again, oftentimes we do start with non-operative treatment for this. Um, Oftentimes you start with, again, activity modifications, avoiding the types of activity that bother the patient the most. We oftentimes consider anti-inflammatory medications, and anti-inflammatory medications are similar to ones like ibuprofen, naproxen, which are over the counter, as well as various prescription type medications as well. We can also, just like any arthritic joint in the body, can perform steroid injections within the knee joint, within the shoulder joint. That kind of helps provide anti-inflammatory effect locally within the joint. We sometimes prescribe physical therapy for shoulder arthritis as well, particularly if there's a rotator cuff tear component with it. But unfortunately, physical therapy does not seem to work as well for arthritis as it does for rotator cuff tearing, simply because when the joint surface is gone, trying to force more motion through the joint tends to aggravate the patient's pain. Now, surgery for arthritis is a lot different than rotator cuff. For rotator cuff, we're able to preserve the joint and repair the tendon, whereas when the joint goes bad, we oftentimes have to then change to a replacement option, or what we call arthroplasty. And there's two types of shoulder arthroplasty. There's what we call the anatomic arthroplasty, where we replace the ball with a metal ball and the socket with a plastic socket. And then we have the reverse arthroplasty, and that's usually saved for patients with bad rotator cuff problems with arthritis, in which we actually switch the two components around, put the socket on the humerus or arm side, and the metal ball on the shoulder blade side. And we'll talk a little bit more about that here in a second. We'll first start by kind of showing something unique that we have now with kind of the progressive technology. With the company that I use for my shoulder implants, we're able to digitally do the surgery beforehand. So we do this by obtaining a CT scan of the shoulder, which we're able to upload into a special program where I'm able to trial digitally different sizes for the shoulder. And actually able to take the arm through a range of motion through the digital program to kind of see which sizes are the best fit for the individual patient. And then, it's just even newer technology is at the bottom here. For patients with really bad arthritis, where there's unique deformity of the glenoid, we're actually able to print a 3D print a guide specific to that patient, to allow proper positioning of the replacement, to avoid any complication associated with that. We tend to save that for patients who have really bad deformity, But I tend to get a CT scan on all of my patients to kind of help do the surgery before I even get in there, so there's really no surprises. We've had good results with that. We'll first talk about the regular shoulder replacement or the anatomic replacement. I have a little model here. But we replace the shoulder for when somebody has arthritis, but still a good rotator cuff. Problem with doing a replacement if somebody does not have a good rotator cuff, it fortunately causes the shoulder to fail, just much like the initial shoulder got arthritis in the first place. Basically, what we do with the surgery here, we replace plastic socket, or sorry, replace the bony socket with a plastic socket. We grind away the worn surface and cement a plastic socket in place that fits the patient's shoulder blade the best. And then on the arm side, we impact a metal stem, something similar to this. It's actually about the same size as this. It's pretty small. We impact this into the center of the arm and then place a metal ball on top of that so that when the patient, when all is said and done, has nice, smooth joint surface to allow the range of motion and pain relief that they desire. Now, the reverse replacement is quite a bit different. This reverse replacement was designed in Europe in the 1980s and has only been available in the United States since the early 2000s. But before this was developed, we did not have good options for patients with bad rotator cuff tears with arthritis. And so this prosthesis was designed to allow patients to raise their arm using the other muscles of the shoulder, particularly the deltoid muscle, which is the very large muscle on the outside part of the shoulder. And the way it does this, it actually changes the rotation of the shoulder to allow the deltoid muscle to do all of the work. We save this reverse for patients who have very, very bad arthritis where we can't do a normal shoulder replacement with, or somebody who does not have a good rotator cuff tendon. And we oftentimes do this for patients with really bad fractures of the shoulder where we can't reconstruct the pieces together. So like we said earlier, with this shoulder replacement, we actually reverse the two components. With the shoulder blade right here, we actually screw in this metal ball that acts as the new ball of the shoulder. And then in a similar fashion, we place the stem, impact that into the bone, but then place this plastic socket on top. So again, this allows for nice smooth joint motion, but it relieves the shoulder of needing that rotator cuff tendon to raise the arm and allows the deltoid muscle to do it. And it does this by actually lengthening the arm a little bit. So the arm is a few centimeters longer than it was beforehand. And it changes the rotation of the shoulder to allow, like I said, to allow the deltoid muscle to do all the work. Now, recovery after either shoulder replacement is about the same for both the regular replacement and the reverse. Similar to the rotator cuff, the day of surgery, we have the anesthesiologist perform the nerve block again, because again, we're not really using the arm much for first 6 weeks after surgery. It is helpful for alleviating pain and decreasing the amount of anesthetic that we have. Sorry. However, unlike the rotator cuff surgery, I typically keep patients overnight in the hospital just because it is a little bit more involved. It's a bigger incision, and I want to make sure that their pain is controlled before going home. Now, recovery after a shoulder replacement is similar to the rotator cuff in that you're in a sling for 6 weeks. The whole point of keeping patients in the sling for 6 weeks is to allow the shoulder to heal, the components to actually, the bone to actually grow into the components, as well as to help. We have to cut the front rotator cuff muscle to go through, so we have to let that heal. However, like the rotator cuff, even though you're not using the shoulder for the first 6 weeks, you are participating in therapy to get your motion back initially. Once 6 weeks passes, we get the patient out of the sling and start having them use their arm normally. I do quote the patients that total recovery is 6 to 12 months, but it tends to be, in my experience, around the 3 month mark. Patients are feeling really good and getting quite a bit of function back in their lives. Now, with the regular shoulder replacement, we tend to not have any major restrictions with that. However, with the reverse, because it is not a normal shoulder anymore, there are some restrictions to that, particularly with the amount of weight that you can lift as well as certain motions. We typically don't want patients doing a lot of heavy lifting with the reverse replacement, as well as avoiding certain motions, particularly pushing up from behind the back, that can put the replacement at risk a little bit. We tend to save the reverses for patients who are not as active. So that concludes my portion about the shoulder, and I will now transfer focus to the knee. Knee problems tend to be a little bit more common, particularly just I think it's because we obviously walk on our knees. Now the knee is the largest and strongest joint in the body and is comprised of 3 separate bones. There's the femur or the thigh bone, the tibia, which is the shin bone, and the patella or the kneecap. Now on the ends of the bones, there's a cartilage, which is the smooth surface that allows for gliding in the joint. And unique to the knee are 2 of the meniscus. The meniscus are these C-shaped discs that sit between the 2 bones, and those act like a shock absorber, as well as help provide stability to the knee. And there are numerous ligaments around the knee that are very well known to anybody who watches sports. The most common one known as the anterior cruciate ligament, or the ACL. Then you have the PCL behind that, the MCL on the inside part of the knee, and the LCL on the outside part of the knee. Those provide stability for the knee. Now, there are numerous causes for pain in the knee. Most common that we see is just from wear and tear arthritis. However, we oftentimes see tearing of the meniscus, as well as ligament tears after injuries. Now, some symptoms associated with knee pain. The most common thing that we see is pain related to activity. Most knee pain tends to get better at rest and worse with walking and using the knee. Oftentimes, with any kind of knee problem, we do see stiffness, particularly with either getting the knee all the way straight or flexion or bending the knee. We sometimes see swelling in the knee, and this patient right here, the patient's right knee has quite a bit of swelling within the knee, and that can be a reaction to many things. It can be a reaction to an injury, like a ligament or a meniscus tear. It can be a reaction to arthritis. It can also be a reaction to other conditions like gout as well. Oftentimes, patients have what we call mechanical symptoms related to their knee. We tend to call these locking, catching, grinding, or popping. This can be related to a meniscus tear that flips back and forth, causing impingement within the knee. We also can see cartilage causing these problems as well. As the cartilage wears down, the surface is no longer smooth, and that causes grinding in similar fashion to the shoulder. We also can see weakness and buckling in the knee. What happens with pain and arthritis, it causes our quadriceps muscle to not function as properly, and that can cause feelings of buckling or the knee giving out as well. Now, in a similar evaluation of the shoulder, we initially start with a good history and an exam to help kind of delineate what type of where the pain is located. We also initially start with X-rays in the knee. But in our clinic upstairs, we mainly focus on standing X-rays. Oftentimes, patients will come to me having regular X-ray from their primary care physician, where the patient wasn't standing. And however, while that can be helpful, it's not as useful in looking for problems such as arthritis, because when we get a standing X-ray, if someone has loss of cartilage, the space between the 2 bones gets more narrow. So doing a standing X-ray definitely gives us a better overall look at the knee. We're also able to see deformity of the knee, particularly as it pertains to arthritis. So in these x-rays here, the x-ray on the left, we're looking for the space between the two bones. So obviously we can't pick up cartilage on the x-ray, but as in a patient with healthy cartilage, the space between the two bones is usually symmetric. Then this patient on the right here, we can see the red arrows that there's complete loss of the joint space. So as the cartilage wears down, we get a standing x-ray, the space between the two bones gets more and more narrow until it eventually becomes bone on bone. We sometimes get MRIs on the knee as well. Now, when arthritis, like the patient on the right, is the cause, an MRI typically does not help us too much because the arthritis is the source of the pain. A lot of people with bad arthritis have questions about their meniscus. Meniscus tears tend to happen with arthritis as well. However, when the joint is completely worn out, addressing the meniscus does not typically relieve the underlying pain. Now, an MRI is obviously has most utility when the patient has good joint space on their x-ray. And we're mainly evaluating things like the meniscus, the cartilage, as well as the other ligaments. And we can evaluate the bone because sometimes patients get bone bruising as well. Now, for treatment of the knee, again, the vast majority of the time when a patient presents to me, we focus on non-operative treatment. We initially start with non-surgical treatment in a similar fashion to the shoulder with lifestyle modifications. Exercise is always very good for overall knee health, but when a patient presents with knee pain or early arthritis, we tend to recommend change in the types of activities that they do. Rather than doing high impact activities such as running, we usually suggest that they kind of cross train with cycling or using elliptical or swimming where we're not putting as much force on the knee. Physical therapy has a very important role in treating knee pain as well. Oftentimes patients who present with knee pain have some form of weakness, either related to the pain or disuse that needs to be addressed. And oftentimes patients limp, and limping becomes a habit almost. And so it's important to have a physical therapist sometimes help break the habit of limping to maximize patient's mechanics. Assistive devices, while not the most ideal, can be very helpful for patients with bad knees, particularly we're talking about canes or walkers in a patient who wants to avoid surgery as much as possible. Using a cane in the other arm on the opposite side of the painful knee really can help decrease some of the stress across the knee. Of course, again, similar to the shoulder, anti-inflammatories play an important role for pain relief. We also have some special bracing for patients with knee arthritis, and typically it is bracing related to arthritis in one area of the knee. So in the pictures below on the screen here, see a patient with arthritis isolated to the inside part of the knee. And there are some special braces out there, especially something called an unloader brace, where it actually tries to force the knee to gap open and transfer weight from the inside more towards the outside part of the knee, as you see right here. And of course, with any conversation about treating knee pain, we do have to discuss injections in the knee, which is a very common procedure that we do in the office. And there's many types of knee injections, and there's a lot of research going on about developing new types of therapy to help patients with knee pain. But by far and large, the most common injection that we do is the steroid injection, commonly known as cortisone. And the whole role behind this injection is that it's an anti-inflammatory that we put directly in the knee to provide local anti-inflammatory relief. This procedure it does not require insurance approval. It's very cheap, economical, and can be done in the office. However, and it's great for patients with arthritis, but there can be, and we can do these every 3 months. There can be some potential negative side effects associated with a steroid, particularly if someone has very early arthritis. Too much of the steroid injections can actually cause breakdown of the cartilage long term. A second type of injection is something called viscosupplementation, or what commonly known as the gel injection. These are injections that are comprised of hyaluronic acid. And hyaluronic acid is a compound in every joint in our body, it helps provide lubrication to the joint. And so these injections, the thought behind that is when someone has arthritis, there's a change in the chemistry of the knee, or there's less hyaluronic acid around to help lubricate the joint. So by injecting these hyaluronic acid into the knee, it can provide pain relief from both acting as lubrication as well as an anti-inflammatory effect. Now, these injections typically are a series of 3, once every 3 weeks. And they typically save these for patients with early arthritis rather than advanced or late stage arthritis. Now, the two final types of injections that we'll talk about are considered more investigational. I mean, they're newer types of injections, as well as they just don't have insurance approval yet. The first one is something called platelet-rich plasma, or commonly known as PRP. There's a lot of good science behind PRP, but again, unfortunately, insurance companies are slow to pick this up. Basically, what this involves is an in-office procedure. I personally don't do it. My partner, Dr. Hoy, does. We typically save this for patients, again, with early arthritis or younger patients who are not great surgery candidates yet. But we actually draw blood from you and spin it down using a centrifuge to isolate the platelets. Now, platelets are components of the blood that is usually responsible for clotting. However, they do contain a lot of anti-inflammatory and pro-growth factors. So what we do is we actually cause these platelets to release all these chemicals, and then we actually inject it into the knee to help provide anti-inflammatory effect. There's a lot of good science behind it, and there's a lot of studies that show these are actually better than the steroid injections or the viscosupplementation injections. But like I said, there's a cost associated with them because insurance companies don't approve them. And finally, one thing we'll mention are stem cell injections. Stem cells are a hot button topic, and you can go on any airline and see advertisements for these stem cell injections. Now, again, these are not approved by insurance companies, and we really don't have a lot of good scientific data behind that. So most patients, and of course, they're very, very expensive as well. And so most patients ask me about them. I can't recommend them at this time because they're very expensive, and there's just no good science behind it yet. However, the other 3 types of injections are. And so finally, knee surgery can be an option for patients who have either severe injuries to their knee or have symptoms that just don't get better with the treatments we had previously talked about. Now, arthroscopy can be an option for patients with knee problems as well, and this is probably the most common type of surgery that I do. Knee arthroscopy, again, is minimally invasive. It involves usually 3 or 4 small stab incisions in the knee. And we're able to address problems in the knee minimally invasively. We typically save arthroscopy for patients with meniscus tears, cartilage injuries, or ligament tears. So when patients have like an ACL tear, we're typically addressing this arthroscopically. Unfortunately, this arthroscopy has not been shown to be great relief for patients with knee arthritis. Again, because the underlying problem is a diffuse or significant breakdown of cartilage. So in these pictures here, again, similar to the shoulder, it involves several poke holes within the knee. And in a picture down here on the bottom, again, this is a patient with a very large meniscus tear that we can see right here, that those can be addressed arthroscopically, especially if the patient has good cartilage remaining. Now, knee replacement, again, is a option for patients with bad arthritis who don't respond to non-surgical treatment. Knee replacement is by far and large the most commonly replaced joint in the country, where there's about 750,000 of these types of joint replacements done every year. So very common, very commonly researched. We typically say knee replacement for patients with symptomatic arthritis in the knee that has failed non-surgical treatment. And again, just like with the shoulder, there are different types of knee replacements. There's the total knee replacement, where we're replacing all the surfaces of the joint. As the picture on the right shows, and kind of this model right here is of the total knee. We can also replace part of the knee. Typically, this is the medial part of the knee or the inside half, but we also can replace the kneecap as well if that necessitates the proper treatment. And so what a knee replacement is, it's really is a resurfacing of the joint. Uh, what we do during surgery is we remove the damaged area of cartilage and a few millimeters of bone. We also cut the bone in such a way that it restores the normal alignment of the knee. Patients with bad arthritis will oftentimes either be bow-legged or knock-kneed, depending on where the arthritis is. And so we cut the bone in such a way to restore a straight leg. And then once the um, bone surfaces are cut, we cement the new knee in. So this component right here is the tibia. We cement, this is made out of titanium. We cement that into place along the tibia and then attach a plastic piece that is actually the bearing surface of the joint. And then on the thigh bone side, we cement a metal cap, cobalt chrome is what it's made out of, and cement that into place so that when the patient walks, there's a nice smooth surface and no catching, locking, and severe pain associated with the arthritis. Now, for a patient with knee arthritis, what surgery looks like for them, usually it involves a preoperative appointment with an internal medicine specialist to make sure they are medically safe for surgery. And then the day of surgery, again, similar to the shoulder, I usually have the anesthesiologist do some form of nerve block to help with pain relief. Something unique here at Riverview that we do that I actually had not seen until I came here, and we've had good relief with this, is instead of just injecting numbing medicine around the nerve, we actually use a special tool to use liquid nitrogen and freeze the nerve. Now, this doesn't kill the nerve, but it stuns it for a longer period of time than a anesthetic injection would, and that prevents the nerve from sending pain signals to the brain. And using this, we have decreased the amount of pain medicine that people take, as well as decreasing the need to address stiffness in the knee, because patients are able to tolerate therapy earlier. So once the nerve block is done, we go back to the operating room, and surgery typically takes, again, 90 minutes to 2 hours to finish, depending on how severe the arthritis is and whether or not it's a total or partial knee. The nice thing about modern technology and the modern rehab techniques we have is that we have the patient walking on the knee the same day of surgery. Usually the physical therapists evaluate the patient an hour or so after surgery and really get them up and moving around. Most patients are walking the halls by the end of the day. And the focus on therapy early is just obviously walking, but as well as motion. Knee replacements can get stiff, so it's very important to get as much motion early as possible for those significant scarring. And the vast majority of my patients do go home the next day after surgery and transfer their therapy from inpatient to an outpatient type facility. So the pictures that we have on the right here of the screen are the knee replacements that I use. It's made by a company actually based here in Indiana, up in Warsaw, called Zimmer. It's the Persona knee. And similar to the shoulder replacements, we don't typically get a CT scan, but I'm able to size the proper size of the knee replacement based upon the patient's x-rays preoperatively, which does give us a good idea about the proper size for the patient after during surgery. Now, the total recovery for knee replacement, again, can be long. It's typically longer than a shoulder replacement. Usually it involves physical therapy for at least 6 weeks, usually longer, especially if patients kind of having trouble getting their motion or a little bit of weakness still. Most patients, I kind of quote, it takes about 6 to 9 months to get almost full recovery, but it can continue to get improvement for up to a year after the knee surgery. However, in my experience, most patients around the 3-month mark are already experiencing some relief and getting back to their daily activities. Now, most people who undergo knee replacements are able to get back to most of their desired activity. The only limitation we have with knee replacement, we typically don't want patients to run for exercise because it can cause the knee joint to wear out over time faster. But returning to low impact activities such as swimming, golf, doubles tennis, and walking for both pleasure and for exercise is expected after any kind of knee replacement. I do want to stress patients, though, with after any of these joint replacement surgeries, that it's important to have realistic expectations to it. The whole goal of these surgeries is to, number one, alleviate pain and restore function. This is not, these joint replacements are obviously not normal joint like it was when you were young. These are mechanical joints that can wear out with time, so we need to have realistic expectations of them, kind of what the end goal. And like I said, the goal is to have pain-free daily activities, as well as improving sleep and just quality of life. Now, the next question about knee replacements of how long do they last? Because we do walk on our knees, they do wear out with time, and there's no joint replacements are no exception. However, with modern technology, we can reliably say that 90% of these knees are surviving after a minimum of 15 years, with 85% surviving after 20 to 25. And you have to remember, this is with technology that was in place 25 years ago, and by the time this data came out. So we fully expect with some of the modern technology that these knee replacements would hopefully last longer than that. So that's all I had regarding a brief overview of a very extensive topic of both knee pain and shoulder pain. What we can do now is open up some questions. I'd be very happy to answer some questions in the few minutes that we have remaining in the end of the hour, if anybody has any. So great question about supplements. Um, there are numerous supplements out there regarding joint health, and spend any time watching television or going to the grocery store, you're likely going to see advertisements for this. The most common one that we see are glucosamine, chondroitin supplements. Common one is osteobiflex. Now, the thought behind this is that cartilage is made up of numerous types of material, chemicals, with chondroitin sulfate being one of them. And the thought behind that is if you take a supplement of that, can it help maintain your joint health? Now, I will say that there's no good research behind that, and in my experience, by the time the supplement is digested, there's no way that you can get the intact material to the joints. Um, However, there's little risk associated with those. So if patients are willing to and want to spend their own money doing it, I won't say no. But again, it's usually about a 50% response to it, and there may be a bit of a placebo effect associated with that. Um, but otherwise, there can be other. There's some research being done with different supplements such as turmeric, which can have an anti-inflammatory effect. We just need more research associated with that. But again, that's a very safe supplement as well that probably has a little bit more of an anti-inflammatory effect than chondroitin does. So oftentimes patients who are looking for a more holistic approach to their pain can definitely be an option for them. Another good question. Hip pain and knee pain sometimes are interchangeable. Oftentimes, patients with actually bad hip pain can present with pain referred down into the knee, as well as patients with bad knees oftentimes are limping and don't walk normally because the knee hurts, and that can cause other problems either with the ankle or the hip. So oftentimes that's a good role of physical therapy, is to help address the patient's gait to actually alleviate strain on the other joints as well as the other side of the body. And oftentimes, if the patient does have severe arthritis after knee replacement, it's not uncommon for these adjacent joints to start feeling better as we restore the normal alignment and get them walking normally. think our hour is almost up. If there are no more questions, I appreciate everybody taking the time out of their day to come listen to me. Again, my name is Scott Smith. I am with Riverview Health and Orthopedics. I have offices predominantly 4 days a week. I'm here at our Westfield, our new Westfield location at the corner of 31 and 32 in Westfield, as well as I spend a day a week at our Hazeldale location at 146th Street and Hazeldale. I'm always happy to see anybody with any hip or any shoulder or knee problem, but of course any general orthopedic problem as well.